It's important to align what matters with the older adults to the benefits and harms of various screening tests. If you want a little deeper dive into what and how you evaluate what matters to the older adults, there's a very good toolkit that's listed on the Institute for Healthcare Improvement website. This is part of the Hartford IHI American Hospital Association initiative associated with what we call age-friendly healthcare. It is recommended that you use this as a resource to consider some tools for yourself. The Stanford Letter helps walk older adults through with guided questions to answer what matters to them, and then to convey that to their primary care provider. In 2025, CMS introduced structural measures for hospitals to support age-friendly care, including frailty screening and eliciting patient goals. There's a set of recommendations from the American College of Physicians. Their Choosing Wisely program recommends not using PET scans or CT scanning for cancer. The problem with doing routine CT and whole-body scans is that you find the non-malignant tumors, and it causes a lot of morbidity and mortality just from pursuing those kinds of diagnosis. Consider remaining life expectancy relative to the risks of testing, overdiagnosis, and overtreatment, which is the same rationale behind not using whole-body PET or CT scans for screening healthy individuals. Question: which of the following is not recommended for cancer screening in healthy older adults? A. PET or CT scans. B. Colonoscopy every 10 years after a negative result. C. PSA screening if life expectancy is more than 10 years. Or D. Mammography for women with adequate life expectancy. The correct answer is A. PET or CT scans. The recommendation for choosing wisely is that you get your colonoscopy. It's normal you go each 10 years thereafter. That's their recommendation. Obviously, if somebody has polyps or a biopsy, the gastroenterologist will recommend a 5-year follow-up. The other one is dialysis. Patients have a 7-year lifespan. That's absolute once they start dialysis. Usually it's much shorter than that, so they don't meet that criterion of a 10 years or greater lifespan. That would warrant further cancer screening. Let's take a look at the Welcome to Medicare exam and the annual wellness exam. The Welcome to Medicare visit has various components. They're on the left side assessment part of the slide, and on the right side are the action plans. Many of these are straightforward. They're just like a regular HPI and physical exam. You want to look at the past medical and family history, surgical history. Minimally, you must measure blood pressure. In BMI, however, we like to measure other things, such as pulse oximetry with walking and gait speed. Vision and hearing are required using the mini-cog for cognition. You can use other tests for screening memory loss or depression. Screening again would be PHQ-2 or PHQ-9, and the geriatric depression scale would also work. You want to look at function ability. Do they have any deficits in their activities of daily living or instrumental activities of daily living? You also want to assess for safety. Traditionally, usual clinical practice, we would say, do you wear seat belts or do you wear a helmet while you're biking? In geriatrics, you want to ask, have you had any accidents while driving? Have you had any tickets, near misses, or citations? Has anybody shouted at you to watch out while you're driving? These are all indicators that there might be some driving impairment, either associated with dementia or neurosensory problems. It's important for the action plan for the Welcome to Medicare to create a schedule for current and future screening services. You want to also include some education and try to personalize it. There are different techniques that you can use to identify goals. One is called target practice. You ask the patient to point out on this target to list what's in the bullseye, what's most important to you, and then moving out to the periphery for things that you might want to address down the road at a later point in time. As of 2025, Medicare now reimburses complexity add-on code G2211 when the AWV is performed with other services, which is important for billing optimization. The annual wellness exam is outlined with all of these different elements. You need to include medication review. They require you to put down all the providers that the individual is currently working with. That includes both specialists and primary care. Presumably, you, as a primary care provider, are that individual. However, they want to know all the specialty care, the ophthalmologist, the cardiologist, and so forth. We talked about the geriatric components of memory assessment depression screening and fall risk by doing gait and balance exams. We'll talk a little bit about what those consist of lifestyle changes, and then finally about advanced care planning. All of this creates a personalized health prevention plan. Also consider adding trail making test B or weekly calendar planning activity to assess executive function and fall risk. With health risk surveys, these are just some recommendations. You can measure quality of life. There are tools for doing that. Ask about general health, nutrition, or hearing. Sleep is an important one because nearly 1 out of 4 to 1 out of 5 older adults have insomnia. It's important to do a home safety check, look at their fall risk, and then also driving issues as we talked about. For health maintenance, the annual wellness exam should cover all these points: vaccination, cancer screening, infection screening, endocrine screening, diabetes, hyperlipidemia, and osteoporosis. CT colonography, CPT 74263, is now covered for colorectal cancer screening and is especially useful for patients unable to undergo traditional colonoscopy. It's also important to include in this evaluation the social determinants of health. There are some health systems that have a checklist for these. There are various tools that you can use to cover all these different areas, such as financial well-being, if there's any food insecurity, or transportation. A lot of times, these questions are asked by the med tech or the nurse prior to the individual coming in for the Welcome to Medicare exam. As of 2025, STD/OH screening can be included in AWVs with no copay if done with patient consent, even via telehealth. With physical assessment, some of the important points are to do the blood pressure, height, and weight. This chart is divided up into face-to-face meetings in the clinic versus telehealth. Some of the limitations of telehealth versus the advantages. In telehealth, you must ask about blood pressure, because unless there's somebody there facilitating the telehealth visit, the older adult would have to check their own blood pressure. Ask yourself as a provider whether the patient looks their stated age. If they look older than their stated age, then chances are they actually are biologically older. That's an important indicator for the e-prognosis, or identifying how much remaining life expectancy the older adult may have in terms of gait and balance. It's really important to assess gait speed. Anything less than a meter per second is considered a risk for falls. Sharp and Romberg is where you put one foot in front of the other, and that's a good balance test for screening for fall risk. For the neurosensory exam, Snelling charts, the whisper test, and checking for cerumen are important. You can see on the balance of telehealth that you can ask the individual to read a newspaper and report if they have any problems. For neurology, evaluate patients for frontal release signs, the gel test, and the snout reflex. Also check for cogwheeling, various sensory elements of including vibratory sense, which goes down with increasing age. However, if somebody has loss of vibratory sense in their fingers and in their feet, you might consider heavy metal toxicity as an example, just by focusing or including rather vibratory sense in both the upper and lower extremities. In terms of memory testing, the mini-cog, the telephone inquiry for cognitive status, or the TICS. You can also use the 88 and ask the caregiver or spouse if there are any indications of cognitive impairment for the patient. During the clinical exam, look for proximal muscle weakness, which might be associated with polyrheumatica. A lot of times, the individual will report that they're having problems getting up the stairs. They have to stop after a couple of steps. Also, check for heel softness. This is often overlooked, particularly in the sedentary older adult or the wheelchair-bound older adult. The firmness on the tip of the nose would be normal for the heel. If you feel the side of your nose, that would indicate a softness that would represent a heel unstageable decubitus ulcer. Recent trials showed prescribing antihypertensives in frail older adults is safe and should be considered with shared decision-making. For functional assessment, you want to do the activities of daily living and instrumental activities daily survey to see if they need partial or full assistance. With functional performance, there's a couple of ways that we can test, like gait speed or the timed up and go test. The timed up and go test is shown. This is either 10 feet or 3 meters. You walk out to a point and then you walk back. That all should be done within 15 seconds or less. At the bottom part, the red zones are indications of slow gait speed, so less than 6 meters per second is associated with functional impairment. The next level is associated with future hospitalization, and the third component, less than a meter per second, is associated with high risk of falls. Gait speed tells you an awful lot, which is why it should be used as a sixth vital sign. New research highlights intrinsic capacity and resilience as key predictors of aging outcomes. Consider integrating these into functional assessments. The annual health plan needs to be written as mentioned. You provide a screening schedule, health maintenance schedule, what preventive measures are going to occur, and really hone in on what matters, which includes advanced care planning. Today, we're diving into a case study titled Balancing Prevention and Patient Goals in a 78-year-old Woman. Let's start with the patient profile. She's a 78-year-old woman with a medical history of hypertension and mild cognitive impairment. Her BMI is 28, which puts her in the overweight category but not severely so. Functionally, she's independent in her activities of daily living, or ADLs, but her gait speed is 0.9 meters per second, slightly below the 1 meter per second threshold that signals increased falls risk. Socially, she lives alone and scores high on the UCLA loneliness scale, indicating significant isolation. Her stated goals are straightforward: stay independent and avoid hospitalizations. Moving to the clinical assessment from her annual wellness exam, the mini-cog test was positive, confirming mild cognitive impairment, but the PHQ-2 screened negative for depression. In terms of social determinants of health, or SDOH, she's financially stable but clearly socially isolated. Using e-prognosis tools, her 10-year mortality risk is estimated at about 30%, with a life expectancy of roughly 8 to 10 years. This context is crucial for guiding our preventive decisions. Now, let's break down the key preventive care decisions we made, focusing on evidence-based guidelines and shared decision-making. First, cancer screening. We decided to avoid PET and CT scans, in line with choosing wisely recommendations to prevent unnecessary imaging. Her last colonoscopy was 12 years ago, so we discussed CT colonography as an alternative. It's now covered by insurance and less invasive. For mammography, it's reasonable to proceed if the patient desires it, considering her overall functional status and life expectancy. Second, cardiovascular prevention. We're continuing her low-dose statin therapy and incorporating the Mayo Clinic Decision Aid to facilitate shared decision-making about risks and benefits. However, we avoided aspirin for primary prevention, based on the 2022 USPSTF guidelines that highlight the bleeding risks outweighing benefits in this age group. Third, immunizations. To protect against respiratory infections, we recommended the high-dose influenza vaccine, an annual COVID booster, a one-time RSV vaccine, and the pneumococcal PCV21 vaccine. These are prioritized given her age and potential for complications. Fourth, falls prevention. We addressed her fear of falling head-on, recommended a home safety check, including anti-slip mats and proper cane use, and referred her to a Tai Chi class to improve balance and confidence. Fifth, chemoprophylaxis. We only advised vitamin D and calcium if testing shows deficiency, Otherwise, no routine supplementation. We specifically avoided multivitamins and vitamin E, as evidence doesn't support their broad use in prevention for this population. Finally, advanced care planning. We used the Stanford Letter tool to document her goals clearly. We also discussed driving safety and her preferences for future care, ensuring her voice guides any escalations. This case underscores the importance of personalization, balancing guidelines with the patient's goals to promote quality of life over aggressive interventions. In summary, the annual wellness exam is a great opportunity to clarify what matters to the older adult. It's helpful to use the Stanford Letter. It's a little long, so you might have to send it home with the patient for them to bring it back later. There's usually an advanced care planner at the clinic that can help with this. It's also an opportunity at the annual wellness exam to motivate older adults. The SPRINT study is very informative. Usually, we consider adequate blood pressure control between 140 systolic, but the SPRINT study indicates that if you have a highly functional older adult, to push that blood pressure control even tighter to 120 systolic millimeters of mercury. That's important to consider in terms of physical activity, prescribed dosing. Both resistance, anaerobic, as well as balance training must go hand in hand with all three of those in order to be effective. In terms of nutritional counseling, take advantage of the Mediterranean diet. There is evidence that there's a better quality of life and also a reduction in brain atrophy over time for those that are in a Mediterranean forward diet, specifically or particularly amplified with fish products. Also, consider social engagement. If you have somebody sitting at home and not socially engaged, that could be a trajectory into functional impairment. It's important to get the individual out and socialized in some manner, and that may be in discussion with the spouse or with the other family members. Functional fitness and cognition are now linked to psychological well-being. Emphasize coordination and endurance in wellness plans. In summary, the whole goal is to try to preserve functional independence. There's a lot of the randomized control trials on primary and secondary prevention, excluding the oldest old. We don't know a lot. We have to infer from those studies and again to balance it with active life expectancy. However, individuals that are 85 and older are amongst the highest percentage of growth in the overall population in the developed world. We're going to be seeing people living closer to 100. If you have somebody that's highly functional at 75, a lot of these screening measures might be appropriate for those 75-year-olds. You need to really estimate as to whether this person is going to live to 90 or 100 to consider a discussion about further prevention. There are various sources that we use to help guide us in our preventive measurements, and importantly, we need to balance all of these different kinds of screening tests that we do, particularly cancer screening, with what the functional status is of the older adult, as well as their cognitive status. If they have moderate dementia to severe dementia, it really doesn't make sense to do a lot of these screening assessments. Likewise, remaining life expectancy. If you get somebody with 5 or 6 chronic conditions and they're 75 years of age, the remaining life expectancy is barely going to be 78 to 81. They're under that 10-year threshold, and you would likely consider not engaging in any type of screening from that point forward. One of the geriatric forums is what matters. It's really very important to hone in and understand what the goals of the older adult are or may be to create a patient-centered healthcare plan. That's the conclusion of this presentation. We appreciate your attention and look forward to seeing you on the additional modules that we have as part of this Dakota Geriatrics program to try to enhance geriatric knowledge and skills in clinical practice. Thank you.